Thank you for the organizers for inviting me to deliver this talk on cardiac MRI. It's been a pleasure to be at the Echocardiography Conference, and as Dr. Vishwamitra mentioned, we are complementary to each other, and I think what we learn from each other is very similar, and we have the ability to add some facets of the diagnosis to each other. I am part of the Indian Association of Cardiac Imaging. The IACI is about 10 to 11 years old now. It's about 11 years old. And the association was started with the idea to promote the CT and MR components of cardiac imaging to the rest of India. We are diverse in number. We have about 1,000 plus members in our association, and we welcome cardiologists and radiologists to our association. So I'm looking forward to having more people participate in the IACI. Our annual meeting is in October on 24th and 25th in Goa, and I think Rajesh might say a word or two about that as well when he gets a chance to speak. So once again, thank you to the organizers for inviting me, and without any further ado, I'm going to basically take the next 45 minutes or so, maybe about 50 minutes, to go over both my topics. I have two topics. Today is the basics, and my second topic is on ischemia and viability. Since they're sort of linked to each other in terms of how they move into each other, I'm just going to go through both. If I have time at the end of the session, I'll actually bring up a full case and just walk you through a full case to see how we would look at the interpretation of that particular case. So my objectives are to review the sequences that cardiac MRI offers, discuss it with relationship to ischemia and viability. I know Dr. Burkale is going to speak on cardiomyopathy, so I'm not going to be speaking much on that. And I'm going to supplement it with the current literature. The first thing that we know is that cardiac MR can give you volumetric analysis by virtue of having excellent endocardial and epicardial volumes and good contrast between the myocardium and the cavity itself. You can also look for scar or fibrosis quantification, and we know this is extremely important in looking for viability. And also, you can also use it to evaluate for cardiomyopathies. The third thing that we can use cardiac MR is to look at ischemia and vascular assessment, and I'm going to go through each one of these shortly. And finally, we have interesting things that we can do with tissue characterization and valvular flow assessment as well. In the past, most of our exams would take about 45 minutes to an hour, and we can pretty much shorten it to less than 30 minutes if we do focused examinations. And essentially what we are trying to do is we are trying to get images from the apex to the base of the heart. We're trying to get it in these different chambers. So these are very similar to echocardiography, nuclear medicine, in terms of how you look at the plane. So you can do a standard 2-chamber or short axis views. You can get a standard 3-chamber, which is basically including the aortic outflow tract, and of course the 4-chamber view as well. And you can get the basal to apical short axis views that you see. By injecting gadolinium, which is a extracellular contrast media, we are then able to assess ischemia and the presence of viability, and I'll talk about that. So why are patients referred to cardiac MR? One of the reasons is because of reproducibility. These are not cine images. This is just reproducibility of the axis. So I'm just showing you the 4-chamber, the 3-chamber, the 2-chamber, and also the different short axis views that you get. And these cine views are identical to that of the delayed enhancement views. So you can do one-to-one correspondence of each of these areas to basically look for abnormalities within the different areas. So let's look at a couple of cine views to see how this might be in terms of volumetric assessment. So what you can see in this patient is basically and this again, the standard short axis views that you're very familiar with. You have the 4-chamber view, the 3-chamber view, and the 2-chamber view, and you can see that there is decreased contractility, almost akinesia of the anterior and the apex of the left ventricle. You can also see that there is decreased contractility of the septum on the short axis views as well. So you can pretty much look at each of these very carefully. And then by drawing the endocardial and the epicardial margins, you're able to do it in diastole and systole. And using a modified Simpson's method, we are now able to calculate the mass of the ventricle, the end diastolic volume, and systolic volume, and stroke volume, and so on. We can also look for volumetric analysis by using the flow quantification techniques through the valve planes, is another method of doing it. The next thing that I mentioned to you is to look for ischemia. And in terms of ischemia, what we do is we give contrast. And if you follow the contrast, you'll notice that in the stress images after adenosine has been administered, you can see contrast coming into the right ventricle, through the lung, into the left ventricular cavity, and then enhancing the left ventricular wall. We follow that up with rest imaging and then the delayed enhancement imaging. I'll speak to you a little bit about delayed enhancement on the subsequent images. And what you're looking for here, this is a normal examination where you're not seeing any significant defects, you're seeing a little bit of a defect here in the left circumflex territory. I hope that's projecting well. So what you're looking for is the presence of a stress defect, which is not seen in rest, and which is also not seen on the delayed enhancement images, and that would be an example of ischemia involving the circumflex territory. So again, ischemic evaluation is performed in that manner. This is a slide which I'm going to reuse in the ischemic inviability part of my talk. And essentially what you're seeing here on the two short axis views that I've shown you here is that there is a decreased enhancement that you see here, this little black rim of decreased enhancement in the septum. And you can also see that there is a little bit of decreased enhancement in the inferior wall. So essentially you have an LAD region of decreased enhancement, and you also have a perfusion defect in the inferior wall, which is going to be the RCA territory. And now if you look at the delayed enhancement images, what I would like to draw your attention to is the fact that there is an area of white myocardium with an area of black myocardium. So essentially what we do here is when you give gadolinium being an extracellular contrast media, it goes to areas which are either fibrotic or where you have edema. So what you're seeing here is basically the fibrotic, non-viable myocardium is enhancing on these delayed enhancement images, which we get typically around 10 to 15 minutes after the evaluation of contrast. Now, if you go back and compare the two of them, if you remember, you had an area of perfusion defect in the septum, which is corresponding to the area of the infarcted myocardium. But you also have a perfusion defect in the RCA territory, which is not seen on the delayed enhancement. And this is therefore an area of ischemia in the RCA territory with an area of infarct in the LAD territory. So this is what we mean by ischemia or vascular assessment. Fibrosis can also be used for other areas. So I would like to contrast this image here where you see these patchy areas of increased signal intensity also representing an area of fibrosis within a hypertrophied septum, very different from the clear, sharply defined areas of infarcted myocardium. And this would be an example of fibrosis within hypertrophic cardiomyopathy. The combination of contractility and delayed enhancement can also be used to look for other conditions. So for example, in this image here, you can see that the left ventricle is actually contracting very well. But if you look at the right ventricular free wall, you can see that there is an abnormal paradoxical contraction, maybe even a little bit of bulging out of the free wall distally of the right ventricle, along with extensive enhancement in a right ventricle which is dilated and has increased volumes. So this would be an example of arrhythmogenic right ventricular dysplasia, which can be evaluated on cardiac MRI as well. What other sequences can we use? We used something called dark blood sequences, where we essentially suppress the contents of the cavity. And this allows us to basically evaluate lesions such as this atrial myxoma, which is along the septum. And of course, I'm not showing you the cine view. The cine views will also exquisitely show the classic motion. But dark blood imaging could be used to look for masses within the ventricle. And we can also use dark blood imaging for looking for edema within the wall, as might be seen with myocarditis. This is just an example of a lesion which is seen within the right atrium, does not enhance on post-contrast imaging, and basically is an example of a thrombus within the right atrium. And we can certainly evaluate these common conditions that we are trying to evaluate that may be a source of confusion on echo, whether is it a thrombus or is it a mass, and you can certainly use MRI to problem solve in those situations as well. The newer things that one can do is something called mapping techniques. And what mapping does is it basically looks at the myocardium and it tries to understand the pixel changes within the myocardium in terms of two contrasts that we like to talk about. We call it as T1 and T2. And it then looks at the distribution of these pixel changes in comparison to a normogram, which is also acquired in the same institute. And you see some values over here. I can't read the values myself, but I know that they're above 1200 and 1300 milliseconds. So anything where there is elevated areas of T1 maps is an example of either fibrosis or edema. And this is one of the things that is now used to basically look for finer detail within the myocardium. In areas particularly where you can't make out the clear black and white changes that I showed you earlier on the delayed enhancement images, you can look at it in this particular type of image to understand whether there is some subtle changes or subclinical changes or maybe even a clinical change which you might not be able to visualize on your standard delayed enhancement images. So this is something which we call as tissue characterization. And this might be able to help us assess in terms of either in chelation therapy if you're using T2 mapping or T1 mapping to find those areas of increased abnormality. So for example, in this patient who has amyloid, you can see that there is an area of subendocardial region, particularly along the lateral wall and inferior wall, where if you take the blue as normal, you can see the increased area of T1 shortening here, which is very typical for amyloid. So when you have elongated T1 values, then you basically are very confident of diagnosing amyloid and can even make the difference between AL and the ATTR type of amyloidosis. Similar to T1 mapping, the second type of mapping is something called T2 mapping. And T2 mapping is nothing but looking for what we call susceptibility. So to keep it very simple, anything which distorts the region of the magnetic field in that particular area causes loss of signal intensity within that region. And that can be seen with iron deposition or hemorrhage. Similarly, if you have edema, which is the opposite of iron, then you can get basically increased T2 values because of fluid within that particular area. So on this particular image, you can see that there is a clear difference between how the septum is appearing and the lateral wall is appearing. And this helps us be more confident that there is an abnormality, perhaps more edema seen within the lateral wall. This is taken from Priya and Bhavin's excellent book on cardiac MRI made simplified, and I thank her for sharing these slides with me. And I'll discuss what this case was as we move on to the rest of my talk. So this is another example of tissue characterization. Finally, you can always do valve flow and valve assessment. This is a nice example of hypertrophy of the left ventricle, and you can see the anterior systolic motion of the mitral valve. And not only do you see that, you can also see this jet that you get in the subaortic region consistent with an obstructive subaortic stenosis in this patient with hypertrophic cardiomyopathy. Very different from this patient here who has a dilated ventricle, and basically again you can still see the region of the valve here, and this looked relatively normal when we were looking at it, but when we look at the aortic valve specifically, all of you can easily appreciate the fact that there is a bicuspid aortic valve with significant flow through that particular area, showing which you can quantify as well. So how are these quantified? Essentially what you would do is you would, very similar to echocardiography, you can draw regions of interest in the region of the valve plane, and you can look for flow either through the valve plane, and you can look for even changes of regurgitation if there are regurgitation. This is just to show you the increased velocities that one would get in this particular patient with bicuspid valves. You can certainly get information based on the flow phenomenon. You can take the regions of interest within deep to the within the curve and calculate the forward volume. If there is a discrepancy between the stroke volume and the forward volume through the aortic valve, then you can also evaluate for the presence of any regurgitation through the mitral valve. As I said, I'm going to hold this off to the end of the talk just so that I don't disrupt the flow of the talk. So let's look and see how MRI might be used in a specific situation of ischemia and viability. This is a 50-year-old male who comes in with a previous history of anterior wall MI in 2011, had a percutaneous intervention to the LAD back then, but continues to have pain and also has a TMT positive for ischemia at 7 meds. These are the echocardiography image where you can clearly see that there is decreased movement of the septum, and the septum was basically noted to be akinetic, and as well as the lateral wall was also felt to be akinetic. Now, I'm not an expert in this, and hence I'm not going to try to interpret this for you. This is the same case I had shown you earlier, so now let's look at all the images put together. So you have the short axis views at the bottom from base to apex. You have the 4-chamber, the 3-chamber view, and the 2-chamber view. The 3-chamber view shows you the aortic outflow tract. The 4-chamber view shows you the septum and the lateral wall. And the 2-chamber view shows the anterior and the inferior wall. And what you see here is very similar to what echo has already given you, that information that the septum is pretty much akinetic. And also the thickening of the septum is severely diminished. I don't think this is even thickening at all. It is just probably wobbling around in that particular area. And you can also see that there's significant thinning of the anterior wall. What you also notice is that there appears to be hypokinesia of the inferior wall, particularly as you go towards the apex. So as I mentioned to you earlier, we can now look at ischemic changes by using perfusion imaging. And what you're doing with perfusion imaging is you're giving adenosine at about 140 mics per kilogram per minute, and you're looking to see if there is any areas of perfusion defect, and then you're adding the late gadolinium enhancement images as well. Typically, the rest perfusion need not be done in these patients simply because the presence of a perfusion defect, which you can see on the stress imaging, along with the delayed enhancement, the combination of the two is sufficient for you to differentiate between ischemia and infarct, as I showed you earlier. Now, this is just a pictorial image of each of these phases that you generally look for. You see the contrast coming into the right side, going into the lungs, coming into the left ventricular cavity, and you can draw curves through the different parts of the ventricle, and you can see here that an ischemic area of the ventricle, an abnormal segment, will show this decreased enhancement, which on our images is typically appears to be a dark area. This is an example of a normal exam where there is no stress defect, there is no rest defect, and there is no delayed enhancement. The stress images are on top, the resting images in the middle row, and the delayed enhancement, which is showing you a completely black myocardium. Recollect that the area of infarct that I showed you earlier is white. So white and black becomes a very clear, you're able to differentiate between white and black very clearly. No evidence of infarct, no evidence of any perfusion defect on the stress imaging. Therefore, this would be an example of a normal exam. And this was a patient who came in with atypical chest pain. The CTCA was then done to show that there was normal coronary arteries, and he was treated medically for something else. This is back to our case. So remember, I had shown you this particular case, which showed an area of a stress perfusion defect along the LAD territory, and more distally, you could also see a stress perfusion defect along the right coronary artery territory. And if you remember, the delayed enhancement showed white infarct along the LAD territory, which was over 50% in thickness, which typically means for us that there is very little myocardium left which can recover after revascularization, and we tend to describe this as a non-viable area of myocardium. And you can also see that there, in contrast, there really is no delayed enhancement in the inferior wall. These are just the other images showing you the overall picture. The patient had an LVEF of 46%, went on to get a coronary catheter angiography exam, and you can see here that the patient has diffuse disease, at least in proximal disease in the right coronary artery in 2 different locations, then had a PTCA to improve his viability in the RCA territory. This is the third concept. So I've shown you a normal myocardium, I've shown you ischemia, and now just to show you what an infarcted myocardium would look like. Okay, let's see if I can get this to play. So essentially, if you look at the delayed enhancement views, you can see the LAD territory infarct as shown by the white area of delayed enhancement. And if you look at the stress images here, you can see that the stress images are showing a similar region of decreased perfusion with no other areas of ischemia. So this would be an example of a stress perfusion defect matched with the delayed enhancement, and therefore this is an example of an infarct. So where does ischemic perfusion imaging play a role in terms of, say, stress and in terms of SPECT imaging and PET imaging? One of the problems we have with PET imaging is that we can get artifacts, particularly from subdiaphragmatic areas or from attenuation of the breast, particularly in women. And the ability to see a much clearer area of perfusion defect on the stress CMR images makes it easy to read past or read through these areas of defects that might be seen with SPECT imaging. The other area where CMR can play a role is in the concept of balanced ischemia. And we all know that particularly with SPECT imaging in balanced ischemia, because all three vessels are showing decreased radiotracer uptake, they look very similar on both stress and rest imaging. And whereas on the stress CMR images and rest CMR images, we're able to very clearly identify that there is a perfusion defect in all the three vessels. And this is my reference for that particular article. How does this look for, and how does this appear in the clinical trials? The CMARC study basically looked at patients who had an angiographic prevalence of about 40% of coronary artery disease, and the stress CMR showed a sensitivity of about 87%. SPECT was lower at about 67%, with the specificities of both being 83%. So when you are able to make the diagnosis, both are accurate, but the sensitivity of picking up more of the diagnosis was seen with CMR. Similarly, the GATACAD trial, where the patients all went into ICA or interventional catheter angiography or had cardiac CT exams within 4 weeks, also showed that in patients who had typically stenosis greater than 70%, stress CMR also had similar sensitivities of between 80 and 87%. And here the specificities were a little bit higher, 87% and 73%, for detecting both single disease and multi-vessel disease. CMR can certainly, as I mentioned to you, in one of our patients who basically had no stress defects and no perfusion defects, but you can use tissue mapping, CMR can certainly be a reliable method for identifying other causes of chest pain, particularly patients who come with pericarditis or myocarditis. This is very similar to what I just showed you, just a different article with different numbers. And again, this is a complex study which looks at both per segment and per territory. And I'll just summarize this in terms of comparing it to positron emission tomography. That stress testing with CMR had a high sensitivity of about 89% and specificity about 84%, with the specificities being similar to 87%. So at least based on this article, stress CMR had a slightly higher sensitivity than positron emission tomography with 84% in patients who had a fractional flow reserve calculation in these patients. What about the prognostic utility of CMR? So yes, you're able to maybe find the areas of perfusion defects to a better extent, but does it really make a clinical difference? Does it really make a difference to the patient? And essentially, articles have basically looked at patients with over 9,000 patients in a multi-center trial, and they have come to the conclusion that stress CMR is an independent predictor of mortality, and I'll show you some more slides based on that. Meta-analysis of large numbers basically looked at something similar, and again came to the conclusion that when you bifurcated patients simply with CMR who did not go for angiography, the CMR was as accurate in terms of predicting the presence or decrease of adverse cardiac events as that of interventional angiogram with FFR prediction. So CMR did have a similar degree of confidence in predicting in the absence of, without an increase, in absence of cardiac events in these patients as well. And also similar reduction in freedom from angina on treatment. The CMARC study, again at 12 months, basically looked at the same thing. and they came up with similar numbers as compared to that of ICA. In fact, what they basically said was stress CMR results in reduced use of interventional cardiac angiography in those patients. And recently, though not in the United States, at least in the European guidelines, stress CMR has been raised to a class 1 imaging technique for evaluating chronic coronary artery assessment with a level B of diagnosis. Okay, so what about viability? Viability, I've already shown you a couple of examples of viability. Viability is very easy to see on cardiac MR. Remember, viability essentially is to look at the areas of white myocardium in a delayed enhancement image. And if it's white, it's generally dead, particularly if it's ischemic. I've also shown you some degrees of fibrosis in hypertrophic cardiomyopathy, and you can get increased edema, which also can take up gadolinium as well. However, when you have this very nicely defined area which follows a vascular territory in the appropriate clinical settings, then this is basically similar, just a simple scar that we are seeing in the LAD and the circumflex territories. And you can see that the transmurality of the scar is over 50%, and I'll explain why this becomes important. Compare that to a different patient with only a LCX territory infarct, where you can, I think all of us can very confidently say that the area of white as compared to the area of black is less than 50%. Would you all agree with me? And I think that's, again, just to point out the beauty of CMR is that, the images speak for themselves, and that as long as you're able to get a reasonably good quality examination, you're able to make this difference very easily as to the quantification of scar. So we all know that subendocardial infarcts, which are in this manner here, compared to transmural infarcts, have differences in terms of their ability to show contractility in that particular area, and also in terms of reversibility, in terms of improvement. So this is just an example of another example of a subendocardial scar at 3 different levels, showing you very subtle areas of increased delayed enhancement seen at multiple locations. So the question is, does this again impact the patient? I think one of the things that I've learned the most by taking this journey through cardiac MR is to basically make the diagnosis that as a radiologist, I don't just deal with images, but I deal with patient prognosis. I have to come back and tell the cardiologist or tell my colleagues, and we work together as a team. Dr. Shrikant Sola is the cardiologist who works very closely with us in Sri Satya Sai Institute of Higher Medical Sciences, as is Dr. Rita and Dr. Prayag. And the question they ask us is, okay, fine, the images are very nice. Does it make a difference? Am I going to be able to treat the patient appropriately? And we've all know these stories of where we don't see delayed gadolinium enhancement. These patients go for surgery, and then they have significant improvement in their contractility. So we do know that absence of scar predicts improvement in surgery. But where does this information come from? This information comes from the seminal research taken back to 1999 and 2000 by Raymond Kim, where they basically sacrificed dogs with both subendocardial and transmural infarcts. They essentially cut off the coronary artery to the supply to these dogs for different lengths of time to induce both a subendocardial or a transmural infarct, and they sacrificed them after doing cardiac MR, and you can see that the stains that you see on the histological specimen is almost identical in terms of the size that you see on the CMR imaging. And that was what gave us confidence to say that yes, what you see on CMR is indeed representative of what you see on histology as well, or what would be histology. Again, the seminal article back in 2000 also showed that if the infarct was less than 50%, these patients had significant improvement in their contractility after surgery, as compared to these patients who had scars of greater than 50%, who had substantially poorer improvement in the same region. So this is what really helped us make the diagnosis. I've shown you some sensitivities and specificities from the ischemia protocol, from the perfusion imaging, and now I'm going to just repeat a couple more from the viability side of it. So on the viability side, basically the sensitivity is about 87%. The negative predictive value is about 91% in this particular CMARC trial, which looked at about 752 patients, of whom had about almost 40% had significant coronary artery disease. What about with PET imaging? Again, we know that PET is very good, and this is a relatively older article back in 2012. And you can see here that even in 2012, the accuracy of PET and CMR was similar. Here are the values that you're seeing here. You had about 84% in sensitivity and 83% in specificity. PET was about 77 and 88%. It was a little bit more specific. Here are the ROC curves to basically show the same thing. So yes, so PET and CMR, you can see here, are very close to each other. The red line, which is on the outside, is PET because it has a higher specificity as you go towards 0 there. What about the other clinical trials? We know that the transmural extent of gadolinium relates to recovery after of function after revascularization, and the sensitivity of prediction of the obstructive coronary artery disease, even compared to FFR, was actually excellent with CMR, with the highest prediction of about 88%, so as compared to that of the FFR, so for obstructive coronary artery disease. These are the different types of enhancement that one can get. I've shown you normal and I've shown you myocardial infarctions, because essentially myocardial infarction is part of this talk. But you will hear Dr. Burkley speak a little bit more about different types of enhancement. And for example, this is a patient who's got replacement fibrosis with aortic stenosis. Diffuse fibrosis also can be seen with stenosis, or you can get these patchy areas of enhancement with hypertrophic cardiomyopathies. You can also do the native T1 mapping, which I also mentioned to you earlier, which can pick up even larger areas of abnormalities. So the use of mapping techniques allows us to look for areas which are not necessarily as easily seen on the late gadolinium enhancement alone. And this is from this article, Assessment of Myocardial Fibrosis with T1 Mapping in 2016. Of course, we know that ventricular remodeling prognosticates outcome, and I've already shown you that. But CMR can also look for other areas which are significant. And this is an example of a different patient who has a large thrombus within the left ventricular cavity, and the ability to find thrombus would certainly change the management on these patients and prognosis. Similarly, one can look for edema changes. As you can see here, this hyperintensity, this increased signal intensity within the wall of the myocardium in the anterior and septum is typical for edema. And you can see that in this patient who has a relatively acute presentation of MI, you're seeing not only the edema, but you're also seeing areas of delayed enhancement within the region of edema, which you expect. But you are also seeing areas of non-enhancing areas, which we call microvascular obstruction, where contrast is not getting to that particular area at all. And we know that microvascular obstruction, which is shown here pictorially in this same patient, has a poorer prognosis in the long term in these patients. And when you do mapping in these patients, we also notice that microvascular obstruction can correspond to areas of hemorrhage as well. So these are different mapping techniques shared with me by Dr. Pudiyavan from the Kovai Medical Center in Coimbatore. And though you can see the MVO quite nicely within an area of surrounding infarct, you can also look for changes of hemorrhage within that. And basically, there's a very nice article which the Indian Association of Cardiac Imaging just reviewed recently in our journal club, where what we looked at was, or what was presented to us, was the presence of hemorrhage within areas of microvascular obstruction that was previously seen, but the MVO disappears but leaves back in its place a region of hemorrhage which has a poorer prognosis. So this was just basically the Kaplan-Meier plot showing you that areas which showed hemorrhage even in the delayed images had a poorer outcome as compared to the areas which do not show hemorrhage within the area of infarcts. So what about stress and viability? I've shown you imaging on ischemia and I've shown you imaging with viability. What happens if you put them both together? Do you get any additional information? This is just a summary slide of all the things I've spoken about so far. Absence of ischemia, absence of delayed enhancement, normal catheter angiography, presence of ischemia shown by the perfusion defect in the RCA territory, absence of any whiteness in that same area, which means there is no dead myocardium or no fibrotic myocardium, so this is purely ischemic, shown by the focal stenosis on cath in the RCA territory. The presence of a perfusion defect with a concurrent or matched defect on the delayed enhancement, and this is an example of an infarcted area. In this type of situation, what we are trying to do is evaluate the thickness of the infarcted area. Is it more than 50% or less than 50%? If it is more than 50%, it's transmural, and these patients have a poorer outcome in terms of revascularization. If the infarcted area is less than 50%, they do much better with prognosis. And finally, the presence of both ischemia and infarct, like I showed you earlier. This is another example where you see the perfusion defect in an area where there is no infarct, but you see an area of infarct in a different location as well, right? So you may be asking me, okay, so I see the infarct here, why is there no perfusion defect seen on this particular image in exactly the same location? So the answer is that sometimes you may not, if the perfusion is not the perfusion defect is not as significant, you might not see the perfusion defect well here, but you know that when you do see the perfusion defect, you can be confident about the ischemia, which is why the sensitivity is at about 87% and not closer to 100%. So what happens if you now triage these two patients into those patients who have the infarcted myocardium, and then you add the presence of ischemia or absence of ischemia, and you can see that there is a substantial difference between both groups. So adding the ischemia protocol to the viability protocol adds to the significance in terms of future cardiac events in these patients as well. So in a multi-center trial, 9,000 patients, 48,000 patient years. They followed the patient up for multiple years, about 5 to 7 years. Stress CMR, again, was an independent predictor of mortality, as I showed you in the earlier exam. And this is just putting it all together in terms of a graph where you looked at the combined outcome and basically showing you the same thing that I've discussed so far, that patients who had ischemia with infarct did poorer than patients who had only infarct without ischemia. And this again showing you something similar. This is basically inducible ischemia and unrecognized MI. And basically, this is actually an interesting article because these patients were not known to have coronary artery disease. And so they took about 2,000 patients over a period of 1 year, and they basically, and without known coronary artery disease, and they did CMR in these patients, and they found that many of them had inducible ischemia with unrecognized MI. And as you might expect from the previous slide, the patients with ischemia and MI clearly had a poorer prognosis in terms of future MACE events. So yes, so this can even help you even when you do not suspect necessarily to have, when the patient is not suspected to have coronary artery disease. What additional information can CMR give us? So I've walked you through ischemia, I walked you through infarct, I walked you through the combination of both, and I walked you through some basic sequences earlier. Is there something else that we can do other than T1 mapping and T2 mapping, other than looking for microvascular obstruction, hemorrhage within that particular area? Is there something else that we can do? We don't do this, but this sounds to be very interesting, where you can actually do stress perfusion maps, and you can quantify the stress perfusion maps in order to actually give you the coronary flow reserve in these patients. This is from Dr. Peter Kellman's group. Kocha is the senior author on this, recently coming out in 2019. And basically what they're trying to show is that you can actually quantify the coronary flow reserve in different portions of the myocardium. We can do global strain evaluation with CMR as well. I think ECHO clearly has a stronger ability to look for global strain. I've not shared any strain images with you. This is again from the Peter Kellman's group, where they basically looked at the CFR in this patient, and basically the CFR was relatively normal, and hence this patient was treated for non-cardiac pain. You can see a very normal appearing coronary artery in these patients. What about this type of patient that we see here, where you can see something which clearly has an infarct, right? You can see the delayed enhancement showing you a large area of delayed enhancement. And the coronary arteries are surprisingly, there is abnormal coronary arteries, but not more than 50%. So where does that leave us when you see something like this? This is from our institution, very similar to what I discussed earlier, where coronary arteries are, the catheter angiography is not really giving you an idea about about significance of the coronary artery abnormalities, yet these patients might have some degree of distal microvascular obstruction or distal problems, and this patient went on to get medical management and also had this unsuspected left anterior descending infarct, which you saw on the delayed images. So this brings us to the concept of basically looking for coronary microvascular obstruction and for looking at changes where the coronary arteries can be relatively normal. So this is just an example of a 66-year-old male. Again, thanks to Priya for sharing this. Priya and Dr. Nitin Burkale work together. So I'm sure Dr. Burkale is very familiar with this patient. This patient came in as a 66-year-old man who came in with epigastric pain, dyspnea on exertion, chest discomfort, elevated troponins, had a cardiac cath which looked normal, both the RCA and the LAD and the LCX territory. And this is an example of somebody who might be having myocardial infarction in the presence of otherwise normal or less than 50% coronary artery abnormalities. And what you see here is basically, let me see if this starts to play. Yes. As you can see here, there is no regional wall motion. Okay, I'll let this play for a little bit. It seems to be a little staccato, but I'll let this play. You can see that the contractility is uniform across the myocardium on these views as well. Right? So you can see the 2-chamber, the 3-chamber, and the 4-chamber views are relatively intact. Okay. And on the delayed enhancement, what you see here is, let me ask you before I tell you what it is. Do all of you think this is a normal delayed enhancement, or do you think there is some abnormality here? How many of you think it's abnormal? Okay, excellent. So I think I've done my job if most of you are saying that this is abnormal. And what you see here is there's some irregular or patchy areas which shouldn't be there. Remember, you should see nice black myocardium, but instead what you're seeing here is this patchy areas of white changes that you're seeing here, right? So this is not in a vascular distribution. You can see the subendocardial area is relatively preserved. Another example of the same. And you remember I showed you the T1 mapping and the presence of fibrosis and edema. This is again from that same patient. And I know that it will be difficult for you to appreciate it if you're not doing T1 mapping regularly, but trust me in that these values are high. So the presence of high increased values can be seen with either fibrosis or can be seen with edema. And when you do an edema protocol, you can see that there is edema seen along the lateral wall, though there is patchy fibrosis seen diffusely. So we have a patient who has relatively normal contractility, no evidence of any perfusion defects, and basically came in with having chest pain and both edema, which is some form of myocarditis, and also some forms of fibrosis occurring in the septal wall. And this patient went on to have a PET scan, and you can see this patient has got small lymph nodes which are taking up the FDG PET, and this patient was an example of cardiac sarcoidosis. So in summary, with cardiac MR, it's a non-invasive multiparametric evaluation of ischemic heart disease. There is a limitation in that it can be technically challenging for the beginner, and that you would therefore need to get some training in terms of cardiac MR. And one of the things that we can do is, particularly with the Indian Association of Cardiac Imaging, is we have multiple training initiatives. I would request anyone who's interested to come to our courses starting in October end at the Goa conference, at the annual conference. And again, you have some wonderful training locations, including Dr. Burkale's own lab, Dr. Priya's lab as well. They do some fantastic work, and we have many other locations. Dr. Rajesh Kannan similarly does a lot of work as well. And our aim here is basically to disseminate knowledge and try to improve patient care. That's really our aim with all of these things. I also showed you that we have the ability to offer more. We can do some mapping techniques, some stress perfusion and quantification, and we have exciting times ahead. So I've taken about 45 minutes of my talk, and I have about 5 minutes left. Let me see if this works. What I thought I would do is just walk you through one case in completion, and let's see if I can do this. Okay. And this is always a little tricky because the angle at which I'm trying to see the screen is somewhat difficult. Okay, so let's see what this one is. Okay, so this is what we typically do. As you can see here, on the top left-hand corner, we have what we call dark blood sequences. On the middle image here, you have what we call bright blood sequences. And this is just an image which we get through the mediastinum from the lung apex all the way down to the diaphragms. And we use this to basically plan out our two-chamber views, and from the two-chamber views, we're then able to plan out the short axis views and the four-chamber views to get a double oblique projection of both. Okay? This also gives us the ability to look for additional findings, such as maybe a pericardial effusion or lymphadenopathy in these patients. Okay, let's see if I can play this. And again, it's a little slow. It's not contracting. It's not playing at the same speed at which we tend to evaluate these patients. But this is the four-chamber contractility view and the three-chamber contractility view. Does anybody recognize anything which is abnormal on this? Yeah. So there's something in the left ventricular apex which is not contracting very well, and you can also see something within the cavity of the left ventricular apex which is sort of hypo-intense on this imaging, where you can clearly see which is separate from the blood pool. You can see that this is within the cavity because the wall is actually more distal to it. Let's see if I can see what the next sequence is. I have absolutely no idea what I'm clicking on here because I can't see that. What's this one? Okay. So this is just the short axis views, and this where you can basically see the contractility. You can see the papillary muscles, septum, free wall of the right ventricle, inferior wall. And this is just how normal images look like. This is what we try to get at for most of our cardiac images. Okay, let's see if I can go to the next one. I want to see if I can scroll down. Rajesh, can you tell me whether I'm somewhere close to the delayed enhancement views? Which one? This one? What's this? No, one above that? Oh. So these are just the outflow tract views, and this is the phase contrast views that we do to look for flow. And as I mentioned to you, the advantage of cardiac MR is that we can measure flow by volumetric analysis using the modified Simpson's method. And we can also use cardiac MR to basically look for flow across the aortic valve and thereby deduce the actual amount of regurgitation or any multivalve disease that we have. Okay. Okay, Rajesh, where am I right now? What's this? That's the perfusion imaging. Okay, so I'll just I'll keep the perfusion up and let you take a look at this. So this is how we do perfusion. I'll let it play once fully. Okay. And you can see here, the perfusion is a free breathing sequence. We use the motion correction algorithm to basically reduce the amount of motion. You saw the right ventricle, the lungs, the left ventricular cavity, and now you're seeing the left ventricle itself. Okay, so that would be our stress perfusion. Rest perfusion is really not required. Just trying to find my delayed enhancement views. What's this, Rajesh? Okay, so on the delayed enhancement views, the patient is getting a little tired by now. You're seeing a little bit more motion on these images, but you can all appreciate the fact that there is a delayed enhancement through the distal septum, the apex, that you're seeing here, and you're seeing that structure that we saw earlier. Which view is this? That's again, and these are all real-life problems that we have. You do have some motion on some of these images. And you can see here on this image that there is, maybe a better image. Next one may be better. Let's see if I can show you the next image. Okay, so what you're seeing here basically is we have two different types of images that we can get. This is called the MAG image, and this is called a phase-sensitive inversion recovery. I won't bore you with the physics of it, but you can use these views to basically look for, to try to improve the ability to decide whether there's enhancement or not. And you can see the area of delayed enhancement that you're seeing there. And you can see here on this particular image that area which was in the left ventricular apex is showing no delayed enhancement. It's within the cavity, and that's just a nice example of a large thrombus within the left ventricular cavity. And you can again see the transmurality of the infarct in the distal LAD territory that you're seeing here. So with that, I thank you for your attention, and I will stop on this particular case.
Dr. Sanjay, what is the status on patient with left bundle branch block and a pacemaker, where we actually get a problem with the PET scan, not the PET scan, the nuclear scan?
Right. So we can certainly, so in terms of just looking for ischemia and viability, as I mentioned to you, to look for any changes in perfusion, it's very easy. You can see ischemia and viability regardless of the bundle branch block, as long as there's no significant intermittent arrhythmias within that particular patient. And with the left bundle branch block, we typically see the abnormal dysynchronous contractility as well. We see the decreased ejection fraction in many of the patients. We can also often see the degree of some fibrosis. Some of these patients with left bundle branch block also have some degree of changes of fibrosis in the septum as well, and we're able to make that out as well. And yes, so we have no trouble getting good quality images as long as they don't have significant arrhythmias in between.
Yeah. And just one more. In most of these cases, they are so unstable that if you keep them in the MRI for a long time, they cannot tolerate.
Absolutely.
So is the acquisition time very short, or what is the average acquisition time?
So we've done several patients with LBB with left bundle branch block, and even patients who just have very poor ejection fractions. They come in with 15%, 20% EFs, and they really have a hard time holding their breath or cooperating with the examination. We do have free breathing sequences which we can use in many patients. The ability to evaluate for the volumetric changes with free breathing is in progress, is something that we can do on some newer software, but is still not something which is routinely done. But we can certainly we can use free breathing sequences to evaluate those patients. We also have some very fast sequences which are typically acquired in about 3 to 4 seconds, or less than 3 to 4 seconds. And at that speed of acquisition, then you can sort of minimize the motion that we get within the ventricular wall. But having said that, there's always a trade-off with MR. Yeah. So the faster the sequence that we use, there is a little bit of a drop in terms of the signal to noise that we get. When the patient is able to hold the breath a little longer, we prefer to have slightly longer sequences so we get better contrast within. And you saw on the patient that I just showed you that towards the end of the examination, he was getting tired as well. But you're still able to relatively well get the information that the clinician requires.
Yeah. Before I open up the discussion for the audience, I have a small question for you. In a patient, delayed presentation after a STEMI is quite common, all over the country, I suppose. So, there used to be a time when after echocardiography, seeing a normal valve thickness should make us happy before going for an intervention, thinking that it's still a viable myocardium. But as we have learned over the times, that much of it is myocardial edema.
Right.
So, do you kind of suggest that if patient is presenting, say, after 48 hours or so with a normal muscle thickness, apparently on echo, we should subject them to routine cardiac MR before proceeding for delayed interventions?
That's a difficult question simply because most of our literature and the image that I showed you as well, except for that one case of acute MI with a microvascular obstruction where you clearly see the edema, most of the time we tend to see the patients later. Typically, even 6 weeks to 12 weeks later when they've had some degree of fibrosis, some degree of stability which is already set in. The edema, as you know, disappears typically by 2 to 4 weeks. The edema has decreased substantially. But if you do choose to image a patient, we can. There's nothing to stop us imaging those patients. If the patient is stable enough for us to image it, then we can certainly give you the information. I don't know if the literature which necessarily supports, how often it helps and how often it doesn't help.
Okay. Yeah. So now it's open for discussion, please. You can use the mics, please.
In acute MI situations, obviously it can be a very good accompaniment. As Vishwamitra has already said, delayed presentation after 10 hours, 12 hours, we often get them. Is there anything called an open gantry MR which can prevent the claustrophobia and things like that? And if it is there, what is the quality of imaging that we can use? Because in a closed gantry lying for 40 minutes, it's not possible for a patient post-MI.
That's a good question, sir. There is open gantry MR, and the problem with open gantry MRs are that they're typically of either 1 Tesla or less. So we typically do not get as good a quality of the examination with an open gantry MR. I don't have any experience to tell you how many patients who get an open gantry MR actually get good quality images. Do you know of any? You don't. Right, so Dr. Kannan, my colleague, also is not familiar with it. I would basically say that if you are going to do a cardiac MR, it needs to be done on a 1.5 Tesla or a 3 Tesla machine. I would not try to do it on an open gantry MR.
Okay. I have 2 questions. Firstly is, you mentioned about quantification of the scar.
Yes.
So normally, do you always do it visually, or are there any ways to do it more quantified rather than visually, more objective?
It's available. So you can get third-party software, particularly, which can quantify the scar burden that you're actually seeing within the myocardium. You can do that. But having said that, I would say that almost all our quantification is visual. We use the American College of Cardiology 17-segment model, and we do describe it within the 17 segments to tell you exactly how much of scar burden there is. But if you think about the fact that you're trying to decide whether it's transmural or less than 50%, again, I'm talking about the ischemia viability category. I think Dr. Berkeley will speak more about cardiomyopathies where it might be a little different in terms of how you approach it. But in the ischemia viability category, if you're trying to decide whether it's less than 50%, more than 50%, in which territory that is involved, you're actually very accurate, I would say, by just doing the visual quantification.
Okay, thank you. 2 other quick questions. One is on your normal scanning, you are able to visualize edema well.
Yes.
So what extra information would you be getting by doing a T2
Mapping.
scanning?
Yes. So that's actually a very good question. So what we've found is that the T1 mapping and the T2 mapping is able to visualize the presence of edema which you don't necessarily feel confident about seeing on a normal scan. So the fibrosis that you see on a T1 map is not as well seen on the extent of fibrosis, the distribution of fibrosis is not as well seen on the standard imaging. And that's where I think it really helps channel the clinician in terms of channel the prognosis or treatment on that patient. What I don't know, and I'm trying to understand myself, is the significance of the volume of scar burden or edema that you see only on the maps, as compared to the significance of the volume or scar burden that you can see visually on your delayed enhancement examination. Because these are more subclinical. I maybe shouldn't be using the term subclinical because obviously they're presenting with symptoms. But the quantification is clearly less because you're not even seeing it on your routine thing. So I'm still trying to understand in my mind as to how that translates in a long-term prognosis. But the main reason is for us to see the distribution which you don't see on a normal view. To take that question one step further, if you look at the myocarditis protocols that we tend to use, about 6 years back, 2013, 2014, around that time, the Lake Lewis criteria used purely delayed enhancement and a T2 map, not map, but T2 image to look for edema. The new Lake Lewis criteria uses maps because they've realized that it's much more robust if you use maps than if you're trying to use it visually.
Is 3 Tesla necessarily better than 1.5 for MRI scan?
No, I don't think it's necessary. If you happen to have, so most of us either have one or the other. We have either the 1.5 or the 3 Tesla. Either one is going to be fine.
Thank you.
Thank you for this wonderful talk. Just a quick question. What is your experience in children and adolescents? Like, there has been a surge of MIAC cases, and I think the crux of it is myocardial injury. So what is your experience on that?
I think Rajesh is going to speak on that, right? You're going to speak on the same topic?
Are very fast, we can do the imaging, but only thing is if the baby is not lying down or not cooperative, then may need a sedation.
No, I wanted to know whether there was any difference in the findings of the usual cases of cardiomyopathy or myocarditis that you find with anything different in MISC or in children or adolescents.
What we are seeing is almost the same only. We will be looking at the edema, we will be looking at the delayed enhancement, the scar.
Thank you.
Any more questions here? Please come to the mic.
Good evening, sir. Sir, my question is that what is the role of cardiac MRI in evaluating the patient for any chemotherapy like atria-mycin and duocarmycin, if it is leading to cardiotoxicity, it is still superior than the biopsy, or to avoid any intervention we should go for cardiac MRI? And the second question is that if any patient, old age patient, is having bioprosthesis wall replacement, what is the role of cardiac MRI in the pannus or vegetation formation in post-surgical patient? Those who are on bioprosthesis, not on metallic wall.
Sure. For the first question, the main role of cardiac MR is that it has the ability to find the ejection fraction and to compare ejection fractions across time is very accurate, because it's an observer independent type of study. You can basically, if I showed you an image, you can draw the regions of interest, everybody else can draw and so there's the inter and the intra observer variability on cardiac MR is much less than in other sequence and than in other exams, which is one of the reasons why it's actually the gold standard for ejection fraction analysis. So what that simply means is that when a person's got cardiotoxicity and you're trying to decide whether this patient has, and you're trying to compare different things, then it's easier to compare one cardiac MR to the next cardiac MR in the same patient, just in terms of pure volume, pure decrease in ejection fractions. That's one of the things which we tend to use. To answer your second part of that first question, which is do we actually see anything within the myocardium in cardiotoxicity, I am not aware of that. I don't think I know of any specific T1 mapping or T2 mapping which shows any differences in cardiotoxicity. I have to read up on that, so I don't know the answer to that. The second thing is with bioprosthetic valves, in terms of looking for vegetations, I don't have the experience to tell you that, because we don't see many valve patients at our center. Dr. Burkale, can you answer that question perhaps? The ability to basically look for valves in general is very easy. I think we need a mic.
Yeah, you can take the mic.
Thank you. About your first question about the chemo, MRI can have a great role in monitoring for the chemotherapy. Only question is the access and the cost. That's the only I worry. But otherwise, when you start, especially the anthracycline kind of chemo agents, the first thing that happens is an intracellular edema because of that. And that's very beautifully picked up by the T2. So the thing is, you have rise in the T2 values without rise in the ECV, extracellular volume. That's very characteristic of anthracycline-induced cardiotoxicity. Of course, as it progresses, then the extracellular volume will also expand, because by the cell is going to lyse and you are going to have local inflammation and this thing. But this particular dissociation of ECV and T2 is supposed to be very good. Second is that myocardial mass loss is very beautifully picked up by MRI, because you have got such a beautiful delineation of endocardium and epicardium, and you are adding up the muscle, the slices, so you get an accurate cardiac mass. So the second thing that happens on toxicity is the loss of myocardial volume. That's second thing. And lastly, when the toxicity is advanced, then you are going to get replacement fibrosis, which the LG will tell you. Plus, you have got a very reproducible EF in the follow-ups. Plus, with the feature tracking, you get a GLS also. So it's actually a very comprehensive examination for the cardiotoxicity, but the cost and the access is the major issue. So we have to rely on the ubiquitous availability of echo for EF and GLS. And about your second question, I think for the PANAS, ICT is far superior. For bioprosthetic wall and PANAS, or even metallic wall and PANAS, CT is far superior. I don't think MRI will have a good role there, because there are a lot of susceptibility artifacts, because even your bioprosthetic wall will have the metal struts in it, so it's not good for that. Vegetations are generally very chaotic moving masses. The best seen by the real-time imaging like ultrasound or transesophageal echo. MRI, unless they are very big, you won't see them because of their chaotic motion. When you are adding up the cardiac phases over multiple cycles, you may even miss it, or it may look very small also. So there the real-time imaging TE is the best, and probably for paravelar abscesses, PET CT is the best for that.
Yeah, thanks.
Any other questions? Otherwise, can I ask a quick last question? The microvasculature, as you mentioned, is a neglected area, and CFR, is seldom calculated. How do you place cardiac MR vis-a-vis PET as far as CFR calculation is concerned?
So based on what Dr. Kelman's group is doing, it looks like CFR is possible with cardiac MR. In terms of reproducibility, in terms of comparing it to PET, I'm not quite sure, but they have basically shown that you can make clinical decisions with the CFR values that they calculate with stress MR.
Yeah, I think that's really important, CFR, because PET is currently the gold standard for CFR, but MRI can definitely give you a very good correlation. Only issue is the use of GAD. That is the only issue.
Right.
Because unless you give GAD, and many of our ischemic heart disease patients, they are CKD, and that's the only problem.
So I think you have combined two talks.
Yeah.
You were
Yeah.
so and you are. We must thank Dr. Sanjaya, especially because he has to catch a long flight to USA this very night, and despite this heavy schedule ahead of him, he could come here and share the podium and give us so many valuable informations and knowledge sharing on cardiac MR. So thank you once again.
Thank you.
And it was really a pleasure to have you here, and look forward to more interactions with you. So I will hand over the mic now to my co-chair, Dr. Shunit, to introduce the next topic and the speaker.